portion of the program, trying to kind of figure out how I'll frame it because I know it's coming up fast and furious, so to speak. All right, so this is the lecture portion of that. We really only started briefly with male repro, and we really haven't gotten into the crux of it yet. But that's today's ambition, and then we'll dedicate third. I'm trying to figure out how I'm going to do that. I wonder if I'll just utilize the lab time. I have to be on campus. They nominated me for some kind of an award. Don't tell anybody. I didn't do it. I didn't even. I wouldn't have nominated me. Okay. So I have to go to like a get together for that to see if I'm a finalist. It's all right. It's okay. I don't. I probably a hearty handshake. That kind of told me about it. The RMU became me the first year I adjuncted here in '08. I had been at Chatham for a number of years, and I came here, and for some reason I was nominated and received part-time teacher of the year. So I figured it was a match. And then within a year after that, I was teaching here full time. I've been here full time for the last the better part of 15 years. What a country! It's okay. It turned out it only took till I was whenever that was '08 or '09. So it only took till I was 57 years old to find where I really needed to be my whole life. But we digress. All right, let us begin. So, yeah, not spending any additional time other just a quick review of meiosis. Similar for both of us, almost identical, with the exception of what are called polar bodies, whether you did them or not previously. It just means that in the male produces, for every time they undergo a meiotic division, they have four gametes, whereas in the female it's just one, because of these. It's a more unique process. And so, and effectively, this is the interesting part. Uh, Without going into it, the idea of this crossing over. You have what is called a tetrad, four chromosomes close together like this. The two, and these are called sisters, and these are called sisters where they're because they're identical. But the ones in the middle, basically, they can sort of overlap and exchange genetic information. One of the unique ways, interesting ways, we are able to increase diversity in our genetic population of gametes. And then, of course, the law of independent assortment goes along with it. So that's really about what it is. Without going through prophase, I don't want to go through it. It's not on there. I'm saving you the time, but they're showing it to you. Just it's to me, it's very fascinating because effectively, from two identical, the idea of this ability to overlap here and here and exchange little bits of information creates for in this case in the male, four unique gametes, four haploid eventual sperm cells. And there's a lot of different names for it, crossing over, synapses, a zillion names for it. And then in meiosis one, then that's that law of independent assortment. So that basically these they can line up forwards, backwards, forwards, and that also increases the diversity population. So it's not identical. It's like I said, in families, we see family resemblances most of the time, in biological families. I understand I always say that because I have a non biological family. But we're meeting a biological new player this afternoon. My wife's new granddaughter and my new step granddaughter. So all good there. And I don't think we need to compare them or anything like that or go through all these slides. It doesn't really assist in the process. I don't think, because I don't want to reteach that, which sort of brings us really to the male anatomy itself. First thing, okay, we know the scrotum is basically a sac-like structure. Effectively, this is abdominal peritoneal tissue that has descended along with the testes. There's a lot, and I cover this a little bit in the review. There's a structure in the old days, we used to call it the gubernaculum, don't have to know that effectively pulled these down. The whole idea of this anatomical adaptation was for sperm development. Sperm do better out when there's a slightly lower temperature, roughly 3 degrees Celsius. So you're looking at maybe effectively the transition would be 5.4 degrees Fahrenheit. It optimizes sperm production. Okay, that's really what you have to say about that. There's a whole lot of interesting structural adaptations for that sort of influence that, in the sense that there's a very, very elaborate, what they call a pampiform plexus, which you don't have to know, which is an elaborate amount of blood vessels that are able to absorb the heat that's produced by the process of manufacturing the sperm to continue to maintain that gradient. So to speak, and it's the first thing with an infertile couple that they'll talk about. They see a low sperm count. Do you wear boxers or briefs? And go to boxers if you're wearing briefs, because maybe the temperature gradient needs to be a little bit higher in that particular individual. Having gone through all of this as a couple, you know, that is very interesting. The names of the muscles are called, just know them, the dartos and the cremaster, and they are, and I don't care which one is which anatomically, okay. And basically, what they do, typically they make alterations. They respond to cold weather by pulling up. And you see this here is this venous plexus, the artery, the nerve. So effectively, you're dealing with intra-abdominal tissue that's exposed, and that's why it's so painful when when there's trauma or something unexpected occurs, typically a traumatic event. Okay, and we'll get looking at this. And these are a couple of the compatible things that are interesting. Both around the ovaries and the testes, there's a firm layer to make them. It's called the tunica albuginea, white tunic. And that's the hard, firm, sort of like a capsule that encloses it, just like we had in the kidney, except this one is white. And it's true for the male and the female. Then there's a layer of peritoneal tissue that descends with it or is found in the female without it. That's called the tunica vaginalis. So those are two names that you might want to remember. So one's derived from peritoneum, and one is just a natural for an enclosure for an organ that's there. So again, the capsule, basically the albuginea, and you'll see this again in the female. And then we start getting into what the testes are about. All you need to really know is that sperm are produced in something called the seminiferous tubules. Just the way eggs are produced within the ovary, and we're going to talk about follicles when we get to that, mostly on Thursday. But here, seminiferous tubules are a little bit different. There's a number of lobules, and then there's other structures in there. There's tiny muscles that help to propel them. There's other cells that make nutrients. There's interstitial cells of Leydig, which you don't have to know, which produce the testosterone. They're all located in this area that are there. Okay, and then there's a pathway, which I don't ask about at this class, that basically takes you from where the tubules are eventually into the structure that collects the sperm and allows them to mature. Sperm stay and are sort of held in that structure called the epididymis that you'll see that surrounds the. I'll back up just a little bit just to give you an idea where it is. That you can see it just up here. That's a little bit of a part of it that's there, that surrounds and collects the sperm, and it's from there that they are ejaculated when that occurs. So they're sort of held there and then expelled from there at the appropriate interval. So the seminiferous tubule is the site of sperm production, as well as basically everything goes on. So while again, here's that plexus absorbing it, keeping it cool or absorbing the heat. The name for the structure, which you should remember, is called the spermatic cord. That's the structure that contains all of that. And then basically, they've passed through a tunnel in the inguinal ligament. Again, the inguinal ligament is a very interesting area between the pubis, the pubic symphysis, and the anterior superior spine of the ilium. There's a lot of passages, arteries, veins. That's a high traffic area. And one you have to be very, very careful whenever when I would scrub in on a hernia repair, that's the first thing they did. All those vital structures, you got to identify, retract, put something over them so you wouldn't inadvertently do something to them. That's kind of how it works. So this is a better look at it. So this is, again, a sectional look. These are effectively the seminiferous tubules. We're not going to sit here and differentiate between the reedy testes, etc., and straight tubules. And this So the sperm develop and come into here, and all of this becomes, as you can see, you're going to have effectually the body, the duct, the tail, the head. All of this is epididymis, and effectively it's just a series of tubules, and you can see how long they are when you see how they're folded. Just we've seen this repetitively. When I see this, the first thing that popped into my mind, ramen noodles. Just saying. Don't you think so? Didn't you look at that and go, ramen noodles? You're college students. College students exist on ramen noodles. Okay. I give up. I used to get a better response from that. You not saying there's a little package you can just heat up water in a microwave, boom? Thank you. I feel better. Oodles of noodles, that type of stuff. It's all right. We didn't have microwaves when I was in college. Just letting you know, they were in their infancy. Thank you for nodding with that comment of mine. Oh yeah, I could believe that. Why am I getting? I'm an award nominee. You shouldn't be abusing me in this fashion. So this is, and so it's just tubules, and you can see how elaborate they are, and how much, and eventually the end or the very tail of this. Here's the head, all the way down, all the way up. When it finally narrows, that's the start of the ductus, or you used to call it the vas deferens. Again, vas just meant vessel, and that basically is a relatively long structure that carries it up back into the abdominal peritoneal cavity, around the bladder, and eventually joining, because it's a shared system, with the urethra, and we'll go over the anatomy. You can see it there in situ. Okay, big player, testicular cancer. This might surprise you. Most common cancer for men. This is when activity develops. So if you're going to have activity, anytime you get an increase in metabolic activity, and particularly mitotic activity, that's when you start to think about things like this. So surprisingly, it's associated with something called cryptorchism, which is an undescended testicle, which is more common than you think, but relatively easy to remedy. And interestingly, the good news about this, masses are typically, that's a neat thing about cancers. That's sort of a little tell. It's like when we're feeling a lymph node, if it's painful, it's more likely infection. If it's a lump that's painless and it surprises you, then you start thinking about cancer. And it's very, very amenable to treatment. Okay, the most famous person I can think of who had this, okay, even though his career became much more checkered because of blood doping, was the very famous Lance Armstrong, the cyclist. He was a world class cyclist, had testicular cancer, came back, and then whatever the doping incident, but still was a world class athlete. So it's quite remarkable. So everything else are accessory structures: epididymis, the vas or ductus deferens. As you'll see, as the vas deferens begin to get their first component of major fluids from what are called the seminal glands and the output channel for the seminal glands and the ductus deferens come together and form the ejaculatory duct. That ejaculatory duct then picks up the start of the urethra within the body of the prostate gland, and that's how that systems come together. So empties into the head, duct of the epididymis, as you can see, 20 feet in length. The epithelia are not that critical in this particular, but it's a lot of surface area, fluids, nutrients. At that point, they're non-motile. They don't look like the classic sperm that we see. And as you can see, it takes about 3 weeks, and there's a fair amount of storage time that's available for that. And this contracts, again, a fair amount of smooth muscle and ejects it. So 45 centimeters is pretty long, okay? So, I mean, if you're looking about 1.5 feet in length by our measurement standards, through the inguinal canal, opening up and joining that seminal vesicle. This is the idea of the anatomical with the ejaculatory duct, and again, smooth muscle propels it. And when you hear about, and it's a very reliable way of in the old days, we didn't think it was reversible. It is reversible, vasectomies, because now with microsurgery, but this was a very reliable way that did not, because a lot of men were concerned that it would impair function, and it did not. My two younger stepchildren, one boy, one girl, are my wife, her ex had a reverse a vasectomy after her first three kids. So I mean, and that's not an unusual case whatsoever. When you'll see the diagrams, once it joins with the urethra, technically we call it the urethra at that point, within the prostate, because it's surrounded and it picks up secretions from the prostate. Then there's effectively a layer of tissue that is the transition point between in the abdominal peritoneal cavity and out. That's called the urogenital diaphragm, or the membranous urethra, where the urethra is. And after that, within the penis, it's called the spongy urethra, because the main structure that it goes through of the erectile tissue is the cavernous, which means cavernous, large spongiosum. So it's called the cavernous spongiosum, and that really is, you'll see the illustration shortly. And here it is. So here you can see them coming around, joining here as they come around. The ureters are back here. So sort of, we're looking almost at the posterior aspect, the back of the bladder. And now you hear this juncture point with the seminal gland, relatively large. And the formulation now, as you can see, it widens where it begins to form the ejaculatory duct. Then shortly thereafter, the urethra joins it within here, and you can see the widening, and the prostate surrounds it. So when someone, and I commented on this in the review, approximately, I want to tell you, around October 1st of last year, I had prostate surgery, not for cancer or anything like that, but because from the bladder cancer and all the treatments that I had to endure with that, this had become effectively enlarged and had to be lasered, the technique that my urologist used to play, sort of, for lack of a better term, plane that down to recreate the opening. The recovery is not, the latter stages of the recovery are not pleasant, and I'll leave it at that. Okay, and here's the diaphragmatic part going through that diaphragm between, so to speak, inside and outside, inside rather and outside, and now you have the spongy portion of it. This is on the undersurface of the penis. You have the corpora spongiosum, and larger here, you have the corpora cavernosum. Those are the larger of the three erectile structures. What this one does with the urethra in it, functionally, way down here, as you can see where the cursor is, way down there, is because it surrounds it. It doesn't compress it. It just maintains the opening, so it doesn't compress the opening, anatomically speaking. So that's interesting. Here, copulatory organ, vagina in the female, external genitalia, root shaft and glands is the tip that's enlarged, the foreskin, which is present at birth, and depending, and these are interesting, I don't know what the statistics are today, higher risk because it will tear during sexual activity, and that means that creates an opening or a barrier that's damaged that allows sexually transmitted diseases, not the least of which would be HIV, to occur. So it's much more common in males, less so in other parts of the world. So it just depends. If you're of my faith, they do this to you at 8 days old. I demand a recount. Very famous term, it's called a bris. Now they call it a Brit because they changed the S to a T. Don't ask me why. Just saying. So that's it. And ritual circumcision is in with a lot of interesting, if you check that out, Google that, you'll find a lot of interesting cultures are involved with that. Okay, so the spongy urethra, the three cylindrical bodies that are erectile tissue, the spongiosum and the cavernosum are the two that are paired. Fills with blood. This is due to nitric oxide that comes from the arousal portion of any type of sexual activity. Okay, and there's muscles around it and anchoring it, etc. Same illustration. The male perineum is different than the female vulva, but it's effectively, the boundaries are the same. Pubic symphysis, coccyx, ischial tuberosities. all of which I'm sure you covered in AP1. And so that's what it is. It's here. That's that area that we look at the perineum, except and you'll see when we look at the female the comparison between the two, which is not terribly dissimilar, except the exit point is here when we have the urethra and the vagina in this area. Glandular. The seminal glands, again, on the back of the bladder is where these kind of all happens. That kind of keeps it out of the way, so to speak. And smooth muscle that, and this is all part of the process with arousal. It adds, as the sperm are being ejected from the epididymis, a certain amount of fluid. In fact, the bulk of the fluid. And that's by volume, the most of it is fluid in the ejaculant. By cell count, it's mostly sperm. There are hundreds of million sperm. They are negligible in volume. They're very, very tiny. Most of it is fluid that surrounds them. If you look at them microscopically, and you can certainly see one of those images almost anywhere on the internet, you can see a mass of sperm that are ridiculously small, surrounded by a large amount of fluid. So it produces the fluid, and there's a lot involved physiologically. Fructose is the only sugar that sperm can use for motivation, for energy. Citric acid, coagulating enzyme, prostaglandins, all of these are part of the, when you get to the idea of the fertilization process. It's a unit I don't do with this class because we really don't have the time to get all of that in. Okay, in my advanced physiology, we're just doing physiology. I don't have to cover the anatomy, so I can do a growth and development, fertilization, aging unit toward the end of that class. So all of the coagulating enzyme will basically coagulate some of it so it doesn't come out. Again, the context for any of this understanding is sort of the goal of the exercise, if we think of it in an absolute value, is to achieve fertilization. So how does it do this? So the coagulating enzyme, acid base, pH balance, prostaglandins are local mediators that play a role in all of these things. And from this composition, it fluoresces a yellowish color. So in forensics, when they're looking for doing an investigation of rape or some other terrible, heinous crime, you look for, when they say on TV, oh, we're looking for fluids, you basically turn out the lights and use an ultraviolet examining light. Most physicians' offices have. A lot of things, interesting things fluoresce. Certain infections fluoresce, so it's used a lot. So we call it an ultraviolet. It has it's called a Woods light. It's a particular frequency of ultraviolet. I had one in my office because certain infections of the skin would fluoresce differently. So it's something, and it's pretty common. When you look for blood, they do the same thing. They use a chemical called luminol. They sprinkle it at a crime scene and see if anybody cleaned it up. And they might, to see if there's remnants of blood. Because usually they don't do it very. Criminals, let's say, are not necessarily all brilliant in that regard. Okay. So it joins together, forms the ejaculatory duct, then everything continues on and surrounds by the prostate. Well, smaller, but not terribly small than you think, more smooth muscle, and now more chemicals, enzymes, this very important PSA, prostatic sensitive or specific antigen. I've seen both names. Oh, when I say plays a role, we really don't understand specifically how it does this. Okay. So about 2/3 of the overall volume are seminal, about 1/3 is prostatic. Everything else is relatively negligible from a fluid content, and again, all the sperm that are within there, numerically speaking. So the prostate is the milky or the white fluid that's very characteristically associated. And then these are really just additional lubricants, the bulbourethral glands, okay, just for lubrication. Maybe there's a certain amount, again, of pH neutralization that goes on. So, there are certain things that aggravate it. So, half the men around age 50 is a common problem. Once you get, I don't know what the guidelines are, whether it's 40 or 50, They do a digital rectal exam in men when they reach middle age, and they typically start doing what's called PSA, which is a blood test. And that, if it's remarkably high, and then there's an abnormal digital exam, then that speaks to the possibility of prostate disease. If you're treating prostate cancer, then they monitor it with PSAs. Prostate cancer is interesting. It's not I hate to use the term allege. You read a table and say, oh, it's the sixth most common killer of men. Very slowly. It's not nearly as aggressive as breast cancer. There are some aggressive forms. Most of the people who succumb to it have elected not to treat it because some of the treatments have been associated with significant dysfunction sexually. And that's a big player in it. So there's all sorts of things. Like I said, mine came from the treatments I was getting. It's just it, and there's a variety of medications that are used for this. If you ask men my age, for you, your grandparents, don't start. Don't say great grandparents. You'll be in trouble. I mentioned my granddaughter was, my oldest was 22 on the third. Uh, third most common, very frequent. Again, I think that is more for. I don't necessarily buy that. It's like when we got the whole thing with COVID deaths. Like everybody freaking died during the lockdown. Oh, it was COVID related. Well, they might have had that as a diagnosis. Most of the time, they were dying of other things. So there's lies, damn lies, and statistics. Is an old saying. So this is the current treatment, digital exam, PSA levels, variety of treatments that are there. The ejaculant or semen, milky white, because of the prostatic secretions. Half a teaspoon to a teaspoon is roughly, if you want to convert the measures, per milliliter. Look at the numbers. When you explore it, it's an immense amount are necessary to accomplish the tasks because of how many actually survive, how many go up the wrong tube, so to speak, how many are required to bypass a variety of defensive mechanisms, and finally, how many are needed to reduce the barrier that prevents them from accomplishing fertilization. Okay? Alkaline fluid neutralizes a certain amount of acidity both in the male urethra and the female vagina. Again, the acidity, as we'll get to subsequently, is the big player. In micro, we do this all over again when we look at urinary tract disorders. Okay? Mucus is the protector in women premenopausal and postmenopausal. During childbearing years, during menstrual years, it's all about something called lactobacillus that produces acidity. Prostaglandins, as you can see, play a role in facilitating movement through mucus, which is still there. Reverse peristalsis. So this is peristalsis in the opposite direction, not going down, going up, so to speak. Hormones, ATP. One of the things that we were told about when my first wife and I went, there's what's called hostile mucus. I think it has more to do with an immunological response, and this plays a role in suppressing it. So some mucus is incompatible with certain kinds of sperm. Antibiotic aspects to the semen itself, and then the clotting factors that you saw before, okay, prevent draining out, then liquefy it by fibrinolysis so sperm can finish the journey. So there's a lot of very interesting interplay when you look at that. The rest of this is response. You don't, basically, it's something, I don't know whether you did this as the two systems of the autonomic nervous system. It's the perfect example of them working in concert, parasympathetic and sympathetic. People wondered why the late Dr. Stephen Hawking, okay, if you didn't see the movie with Eddie Redmayne, go see it. He won an Academy Award for it. Why they were able to have children. Well, he's confined to a wheelchair. He's got Lou Gehrig's disease. That's a motor system, not autonomic. And he had a famous line, and he goes, "How did you have kids?" He goes, "Different nervous system." That's what this is about. It's that his disease did not affect the autonomic nervous system. It affected him. Any type of excitement, however you want to frame it, leads to the release locally of nitric oxide, relaxes the vascular smooth muscles. They expand, they dilate, it retards. That expansion is so large that it retards or limits venous drainage. And because of the surrounding way of the construction of the spongy open, the urethra is open, all sorts of things, whether they're physical or mental, however you want to describe it. Okay? And then the sympathetic nerves through spinal reflexes are able to create the impetus, so to speak, for all of this contracture, emptying prostate, relaxing the sphincter, etc., preventing expulsion of urine or reflux of semen into the bladder, etc. And so rapid contractions, relatively fast speed. You want to hear a bad joke? 4 more miles, they could get a ticket in the school zone. Obviously bad. Hello? Just think of it in a school zone. I mean, there's an interesting double entendre. I give up. I like to say you've been a good audience, but not today. Just wait till micro. Same lousy jokes over again. And again, for any of the newbies in the class, laugh. When you walk out, just go, easy one. I'll be looking for you particularly, Grace. Yeah. Inherently trouble. Don't start. And then a refractory period, typically, I don't know, at variations, 20, 30 minutes, increasing with age. There's nothing unusual about that. So parasympathetic release too little or none. This is when we get into ED. It's a major problem, and it's probably an increasing problem that we begin to see. And I think a lot of people are looking at it. I think the two biggest culprits are this: antihypertensive and antidepressants. Alcohol is certainly a factor. Psychology, I would agree with all of those. But I think we're seeing, relatively speaking, an increase, and that started effectively an industry, and that's all they did was try to construct a medication. They knew the pathway for nitric oxide breaking down, and so all of the erectile dysfunction medicines, which are advertised forever everywhere, okay, are dedicated to one thing: blocking the enzyme that breaks apart nitric oxide. The longer nitric oxide is active or present, that's how they work. So there's lots of different problems that are associated with it. Diabetes is a big player. That doesn't respond to these kinds of medications. Okay, it should be with a capital O, not in a small o, but that's common for these PowerPoints. Diabetes, one of the areas where we see a lot of vascular damage, arterial supply, not having to do with nitric oxide so much, is in a small artery that's going to the male genitalia, in and around that area. So there's a number of syndromes. I had a very interesting case with that, with a guy who was in his mid-30s, was referred to me by his diabetes. He really had ignored treating his diabetes, never took insulin, terrible diabetic, drank his lunch. Okay, where I practiced, we had a lot of people that was, there was a shot in the beer area, that type of stuff. Big monster guy. I called him a mountain man. Big beard, big guy. Why did he come to see me? Because she told him to come and get his feet looked at because they were potentially a problem. Why did he finally go to a diabetologist in a neighboring town? He had, and this is what got his attention, a problem in the bedroom department, so to speak. And that got his attention. I saw him a couple of times over a year. After about a year, he came in. I couldn't recognize him. He was so much. I said, what's going on? I hadn't seen you in a while. He goes, I'm done. I need a heart transplant. So I lost him to follow up. I assume might have lost him permanently after that. So that is, ignoring problems. The moral of the story is ignoring problems is never a good thing. Be it a guy or a gal, it doesn't matter. You can't ignore that stuff. And a lot of people do. So seminiferous tubules, puberty, around 14 years, 90 million daily. So you don't have to know any of the numbers. These are the other cells that are there, supporting cells. In the spermatogenic cells are the ones that make the sperm. Muscle cells help to push them along. These interstitial cells of Leydig, they are the androgenous or testosterone-like substances. Interestingly, we do see some estrogen in men as well. And in females, we see some testosterone-like substances from the adrenal glands, from the innermost adrenal gland. So it's interesting. There's a lot of overlap. Just showing you an illustration and another illustration, and they go through the whole thing, and I'm not going to go through all that stuff. But you can kind of see this is kind of how they get to the spermatids is kind of how, and this is like for med school, and we're going to do this unit for our MCAT class that I co-teach with one of the professors here. They need to know all these different stages. That's why you certainly don't at this point. They kind of come into the epididymis like this. And by the time they mature, they're like that. So there's a big difference. Again, I'm not going to go through all that stuff. I don't think you need to. Anatomically, they have a head. That's the mid piece and the tail have nothing to do with the genetic aspect. In the head is a small amount of the genetic material and something that covers it called an acrosome. They liken it to a helmet. The acrosome is the thing that has the enzymes to help it to penetrate the outer covering of the egg. The midpiece and the tail are strictly about locomotion. The tail basically responds to ATP from mitochondria in the midpiece. So acrosome is that little bluish area here. Here you can see what they look like in an actual micrograph. Midpiece is where the energy is. And you'll see the difference in eukaryotic tails. They're whip-like. They go back and forth. When we go to micro, you're going to see that bacteria have flagella much, much smaller. They basically are like propellers. So it's a whole different anatomical thing. So a lot of what I do in micro is I compare eukarya, our cells, animal cells, to prokaryote, bacterial cells. Fair warning. Still time to transfer. You want to be subjected to these bad jokes again? Anybody? None of you? You're a glutton for punishment. All of you.
I think you're trying.
Pardon me?
I think you're just trying to get rid of it.
I'm trying. The less I have to do, the better. I got like 7 classes to teach next year. It's really hard. I'm going to be here 3 days a week and busy all day. No time to lounge around, do fun stuff. Okay. Not a whole lot to say here. Important. Sperm are produced after or at puberty. Your body identifies self versus non-self at birth. For the first 6 months, okay, your immune system, anything that's there, it recognizes. These are not. So you have an abundance of tight junctions in the cellular structures that don't allow the sperm to escape into the blood. If they did, you'd have a vicious autoimmune immunological reaction, because they would view those sperm as foreign. They're genetically dissimilar from anything else they've encountered. Okay? So they have to be kept separated. When there's a traumatic incident, somebody has a major injury, it could be a sports injury, it could be a car accident, and they get bleeding in that area, it could disrupt that barrier, and then you have to deal with the immunological aspects of it. So there's not a whole lot that you have to do with androgen binding proteins, et cetera, et cetera. It's a greater problem than most people think. Infertility, this is what we were told, and again, this is 30, 35 years before this book was published. Okay? So we're seeing increases in that. I mean, it's the most limited study in the world. Okay? The baby that my wife and I are going to see today is a product of IVF. My son, my oldest, and his wife, both their children are products of IVF. So there's a greater degree of problems in vitro fertilization that we're seeing today. Obviously, that's just the shortest possible sample of 2 cases in my own family. So I don't know what to make of it. Okay, and these are lots of things that are there that people are talking about. So it was unusual. I would think it was more unusual, and sometimes I think it's just the way the cards are dealt. It's. I know. It would be an interesting topic for discussion. Okay, so foreign molecules. There's a lot more things in our food supply, and a lot of people are very cognizant of that. That's part of the big drive toward organic type foods, trying to avoid pesticides, other environmental toxins. I mean, I'm not a big fan of organic foods because they're expensive and overpriced. I mean, if I want to get organic stuff, I'll go to Aldi's, probably the most affordable ones that I can find. I don't want any. Oh, missed call. Okay, so these are part of it. Plastics, pesticides, herbicides. So I think those are just the kinds of things that you have to keep in mind. So other possibilities, like estrogen-like compounds may be produced. Antibiotics can play a role into it. All of this. Radiation, certainly. Lead poisoning, you don't see that much of. I, it's hard to tell with marijuana. I've got a whole lot of friends who did a lot of marijuana over the years, back in the day when it was illegal, who had no trouble having kids with any problems. I'm just saying. Alcohol definitely can be a problem. So there's a variety of things that are there. I don't make more of that than what it is. Again, this is the regulatory system, same for both. That axis that I talked about before. The whole thing is triggered by, mostly in the male, testosterone levels and maybe inhibin levels. When they start to fall, when testosterone falls, and certainly if inhibin falls, because inhibin basically is also inhibiting the release of this really important chemical from the posterior pituitary, GnRH, gonadotropin release hormone, that induces the anterior pituitary to make follicle stimulating and luteinizing. Follicle stimulating is just that, make sperm. Luteinizing is just that, make testosterone. Same for women. Develop eggs, FSH, estrogen and progesterone, LH. Same controls that are there. So, and this is where it comes from. Follicle stimulation. So, what happens, again, just to summarize it, this GnRH basically induces the anterior pituitary to make these two. Okay, it stimulates spermatogenesis indirectly by this binding protein, and then eventually leads into it. The LH, testosterone levels, and then they play an augmenting role in spermatogenesis. It's twofold, not important for us. Testosterone, just like estrogen, to some extent progesterone, secondary sexual characteristics, libido, all of those things. Inhibin basically is triggered by high sperm counts. Okay, those are the sustenticides. There's like supporting cells that are in the seminiferous tubules and slows down the release. So I mean, it's a well-controlled phenomenon. So as you can see, even at birth, the levels are really high. There's a tiny rise. I don't have an explanation for it. And then you'll see the chart. As puberty nears, then we begin to see these high levels that are able to sort of overcome the suppression response and stimulate the adult pattern. So it's a classic graphic. And you're going to see in the female, it's totally different. because we have that, that limited window of time, let's say in here in the female. So in the male, as you can see, goes down at birth, has a brief spurt. I don't know what accounts for that. Maybe some stimulus for additional development, speculating, and then negligible. And then once it starts, men retain this relatively high level. I'm not indicating, but there's ample evidence of men either with assistance or without being able to have, being able to be the dads of babies, you know, at an extremely old age. What I have seen anecdotally is that a lot of those children, maybe I'm trying to think of words to describe it, some genetic faults, not major faults, but, irregularities that I think impact that, so to speak. I mean, it's interesting as an aside to see that. I mean, we see who De Niro just had a kid. He's like 50 years older. Go figure. So, and that it's just the interactions there. It takes about 3. It doesn't mean that the sperm can't fertilize, but to achieve a rather stable level takes a few years. And in the absence of these, then the whole system would fall. So it's cholesterol based, converted in the prostate, okay, and estradiol in some brain neurons. You can see, if you take a look at the similarities between estrogen and testosterone, they're almost identical molecules. They have a cholesterol nucleus with some tiny little changes. There's not a whole lot of difference in what I produce versus what you produce. Anabolic effects, deficiency impairs all of those things. I think we're familiar with all of them, whether it's axillary or pubic hair, chest hair, voice deepening, like that. Okay, bones grow, skeletal muscles, metabolic rate, libido, and you see the same laundry list for women as well, and that is everything. Aren't you excited? I can't say that you guys have been particularly interactive today. You're about done this week, aren't you? Everybody. Had it up to here. Okay. How many finals do you have next week? 3, 4? 3 days. I don't know. In the morning. Isn't it the 11 o'clock window on Monday? I'm pretty sure that's it.
Yeah.
Before what?
We have this.
You have a double header.
Yeah, then we have a
I'm working on something we might do. I'll let you know. I'm thinking about it.
like good thing or bad. Yeah,
It's a
really good
I
thing?
think it's gonna be cute.
Yeah.
So 8 a.m. on Monday.
Is what?
Oh no, just kidding. 11 on Monday. 8
Yeah.
a.m. Monday.
Don't start. I can't get up that early.
So 11 a.m. Monday.
You're not done yet. Don't. Gotcha.
Can we please be?
Go back and watch your movie. Give me 5 minutes to introduce the topic. Gosh, you guys are awful. You would think you'd want to know about this. Oh, help me. Spare me. Totally spare me. Okay. Anatomically, I think it's a little simpler in the female. Physiologically, it takes a lot of time to understand the physiology. We will not go into it in every gory detail that's there. To summarize it briefly, there are two systems that work in concert physiologically. You have the ovarian cycle and the menstrual cycle, and they're impacted. To view them down the road, there's a slide here that summarizes it. Just like in the heart, when we see all the events sort of stacked up all the factors, all the chemicals. That's when you can get a certain degree of understanding. Very, very complicated. Okay. Anatomically, you have ovaries. There's a significant anatomical difference. Okay. In men, because that not just because of the blood testicular barrier, the way it is arranged, the sperm never see the light of day until they're ejaculated. In women, it is not a closed system. Ovaries don't expel the egg directly into fallopian tubes or uterine tubes or whatever you want to call them. For a tiny fraction, there's a space. They're ejected into the abdominal pelvic cavity, and then they are captured, so to speak, drawn in to the oviducts, same name, fallopian tubes, uterine tubes, all same thing, by little eddies and currents of mucus generated by ciliated cells in the fimbriae, finger-like projections overlapping that are coming from the tubes, appear to be in contact with the egg, but they're not. So immediately, that's problem area number one. There's a significant anatomical difference that rarely, but still occasionally, will lead to ectopic pregnancies. So most ectopics are tubal pregnancies, and there's a variety of factors. There's a little unit on this at the end that I redo in more length with regard to STDs, and it's very I think it's very important to have as part of this discussion. It's the same deal. Primary organs, the eggs, make the ovaries, they make eggs, estrogen and progesterone, different active forms, all located in the pelvic area of the abdominal pelvic cavities, including the duct system, the uterine tubes, the uterus, the vagina, external structures. Voila. Different entire. First thing you see, different major anatomical difference is sort of here you have the reproductive system nestled between the rectum and colon and the anus and the bladder. And this is called anteverted. The uterus sits on top. So you can imagine during pregnancy, when that expands, why there's so much pressure upon it. During arousal, okay, this tense, it kind of points back upward that way to facilitate it. Very interesting, I think. So you can see some similarities, but you immediately can see some differences in the way the location is there. It's it's extremely complicated, even though I think anatomically, here's the ovary, here are those fimbriae. Again, they look like they're in contact, they're not. You have a relatively short, not a long tube. Fertilization usually occurs around here in this neck of the woods. A very large uterus, which is a massive amount of muscle, a very complex lining, part of which is shed during menstruation, a tiny area that's really a problem, the cervical area, but cervix just means neck, between outgoing uterus and incoming vagina, but a significant area because of, unfortunately, cervical cancer, which is, we'll get to it any number of times, even in micro. But here's the statistic. Most authors, 15 to 30% of all cancers are related to virus infections. I would dare say half of those are related to HP, human papillomavirus. And the numbers of people who have been exposed to that virus are extraordinarily high. To me, that is the most prevalent, meaning people who have been exposed to it. And unfortunately, it's once you're exposed to it, you always have it. It's like herpes. Okay, it becomes latent, hopefully latent, and doesn't do anything. It's not something it's treatable but not eliminatable. Whereas something like trying to think of the right word, chlamydia, Trichomonas vaginalis can recur, but they're treatable with some type of antibiotic or antimicrobial substance. So ovaries flanking the uterus, almond shaped, maybe twice as big as your typical almond. Anatomically, it can be quite complex with all the ligamentous structures. Okay? So you have a suspensory ligament to the outside of the pelvic wall, an ovarian ligament to the uterus, more additional connective tissue like the mesentery and mesovarium, all of that, if you add it all up, to me it's called the broad ligament. Without putting too fine a point, everything but kind of that suspensory ligament are all, that's even part of it. I mean, and it's interesting because this is one of those interesting organs where everything happens out here. Blood supply, nerve supply, lymphatic supply is here. Egg development around the perimeter. That's another little interesting aside with this. So in the cortical areas, we see one egg eventually is selected. Not sure how that comes. Typically one on one side, one on the other side, alternating months, and eventually is expelled around here. Okay, so again, blood supply pretty straightforward, just like gonadal arteries, ovarian arteries. Okay, there's even an ovarian branch from the uterine artery. The big deal here is the uterus is principally supplied by a branch. The uterine artery comes off the internal iliac vessel. That's a big player because that's where menstruation comes in down the road. And again, albuginea, fibrous tunic, outside vaginalis, effectively a layer of peritoneum. So you can see here's this broad ligament. So, I mean, whatever you want to call it, it basically is holding things up, securing them to the wall, so to speak. Okay, a lot of structures are there. So, unfortunately, when we get a condition known as PID, pelvic inflammatory disease, which is horrible and a significant problem, and I'm sure it has changed today, but it hasn't gone away today. When I was a resident, every day we saw people with severe complications from sexually transmitted diseases. At that point, it was mostly gonorrhea. We even classify them that way, gonorrhea and not gonorrhea. So many problems with ectopic pregnancies. Once it gets into this area, you're ending up with early misfunctions, early hysterectomies, early infertility, increased numbers of ectopic pregnancies, all that type of stuff, and potentially could be life-threatening. We saw a ton of it since HIV came into focus. Has been an increase in barrier measures like condoms. There's been an increase in more monogamous relationships, and really perhaps some more conscious efforts. And we saw the numbers go down, but there's a certain thing we call out of sight, out of mind. All of a sudden, we begin to see increases in those diseases trending again. It's wild. You'll hear more about it on Thursday, having gone through that era. Here you can see a little bit. So we'll start development. It will go around. Here's the blood supply, nerve, and lymphatics. The egg will be selected here, increase, finally enlarge into a fully developed follicle. A follicle highlighted by is a surrounding. The egg is going to be on the inside. This is called the antrum. That's a layer of fluid that's in there. That will cause pressure and bulging that eventually will develop enough to allow this to erupt. Basically expel the egg, but retain the follicle part of it. The follicle then becomes this because it changes to a yellowish color called corpus luteum, Luteum. Luteal basically implies yellowish color. That takes over, making estrogen and progesterone, and will do so for a couple of months if there's implantation. After 10 days in the absence of implantation, it will effectively shut down and become something called the corpus albicans. It turns kind of white in color and basically atrophies completely. And that absence of high levels, more so of progesterone than estrogen, are what start menstruation. We'll get into all of that as well. So again, cortex and medulla, outside and inside. The tiny follicles are little sacs that are there. They have the egg, and each month one is quote unquote selected. Okay, and ejects it. And then we have the tubal system, fairly straightforward. Uterine tubes, fallopian tubes, whatever you want to call them. Uterus, vagina. And again, it's in the peritoneal cavity. Fallopian tubes, oviducts, another term, not nearly as long as the comparison in the male. We're dealing with 1.5 feet. From the ovary to a superior region of the uterus. The infundibulum is where it widens, where the fimbriae are located. And then you have, and normally between that area and when it narrows is getting close to the uterus, that's where fertilization, somewhere in that like middle 2/3 might be the way to describe it, of the tube. Captures it, sweeps it in, carries it, again, peristaltic action, okay, nourishment from other cells, covered by peritoneum. And when you see the term salpinx, it means that if you see that down the road, that means related to tubes. Years ago, before we had more advances in technology and imaging, they used to, my ex-wife had that, it's called a hysterosalpinogram. They would inject dye into the tubes. I may still do it, to see it. And that was one of the tests they had to do. There was a series of tests they did for infertility. They did, obviously, a physical examination. They did a thing called a PK. We went through this in Philadelphia. You had intercourse first thing in the morning. Very careful not to let anything drain out. Ran to the doctor. They take a sample to see if the sperm are active or not. Is there hostile mucus? They can test all that. That was part of what was done at the workup. If I didn't tell you, we had that workup done at the hospital, University of Pennsylvania, by the person who was considered the world's leading authority on infertility back in 1980, Dr. Celso Ramon Garcia. Didn't work for us, mistreatments. Another couple, friends of ours, who, and unfortunately the lady's now deceased, went to see him about 6 months to a year later, and they have a little girl. Born almost the same time as my oldest, after we adopted my oldest. Pays your money and takes your chances. Ectopic just means it isn't, it's in somewhere implanted where it shouldn't be. Big problems associated, and PID, which we'll get to more. So stop it here. Enough of me. I'll let you know Thursday whether we just do the lab component, maybe find a comfortable place to sit around, rather than me sitting around here all day. So thanks a lot. Gee, thanks for all those questions you asked me and all that interactive stuff today. Your pleasant responses to my bad attempts